Welcome to the deep dive. Today, we're zeroing in on the updated NHS Pharmacy Contraception Service.
That's right.
And this is really for you, the learner, if you want to quickly get your head around the essentials, what's new, without getting totally bogged down in detail.
Yeah, we're aiming for that sweet spot. We've looked at the updated service specification, that's version 2.0 from December 1st, 2023.
Yep.
And the PGDs, the patient group directions, also version 2.0 from the same date. That covers both combined and progestogen-only pills.
Right.
Plus, we've got the absolute latest from Community Pharmacy England, literally hot off the press from May 15th, 2025.
Okay, so our mission, if you like, is to pull out those really crucial updates. What do they actually mean for patients and for community pharmacies on the ground? Let's dive in.
Let's do it.
So first things first, how has the service actually, grown or changed since it first launched?
Okay, so the big initial change, which kicked in back on December 1st, 2023, is that pharmacies can now initiate oral contraception. They can start someone on it for the first time.
Ah, right, because before that.
Before that, yeah, from April 2023, it was only for ongoing supply. Someone had to have been started elsewhere, like at the GP.
So adding initiation is a pretty big step then.
It's a key development, absolutely. Makes the service much more comprehensive.
And speaking of significant changes, I think this next one will be pre-welcome news, the money side of things, the fees.
Yes, definitely. So as of April 1st, 2025, the consultation fee, and this is for both initiating someone and for doing a repeat supply consultation.
Okay.
That fee has gone up to £25. £25.
Wow, okay. That's quite a jump.
It is a 39% increase. And it's really about acknowledging the time and the complexity involved, especially, for that initiation chat, which needs a really thorough assessment.
Yeah, makes sense. It takes time to do it properly.
Mm-hmm.
Now, looking ahead a bit, there's talk about changes to who can actually provide the service.
Yes, this is another important one for sort of boosting capacity. The plan is that suitably trained and competent pharmacy technicians will be able to provide the service as well.
Oh, interesting. Pharmacy technicians too.
Exactly. And this is the crucial bit. It can't happen just yet. The main service specification document and the legal framework, the Secretary of State directions, they both need updating first.
Right, the paperwork needs to catch up.
Pretty much. That work is happening now, but we don't have a date for when technicians can actually start.
So pharmacy teams need to kind of watch this space for the official. Go ahead.
Exactly. Keep an eye on the usual NHS England and CPE updates. They'll announce it when it's ready.
Okay. And there's also news about the actual medicines, specifically adding drospirenone.
That's right. Drospirenone, it's a type of progestogen, is set to be added to the list of drugs pharmacists can supply under the PGDs for this service.
So another option available through the pharmacy route.
Potentially, yes. But again, like with the technicians, there's a slight delay. It can only be supplied once the PGDs themselves are updated to include it.
Right. The specific clinical protocols need updating first.
Precisely.
Yeah.
So pharmacists can't supply it yet. They need to wait for those new PGD versions to be released and authorized. Again, updates will follow.
Got it. Now, moving on to what sounds like maybe the biggest expansion coming up, emergency contraception. EHC.
Yes, this is a really significant development. The plan is to include emergency hormonal contraception from October 2025.
October 2025.
Okay, but there's a caveat. It depends on the IT systems, the clinical software pharmacies use, being updated in time to handle it properly.
The tech needs to be ready. And what about the payment for EHC?
So the consultation fee for providing EHC will be £20. £20, and that's plus the cost of the actual EHC medicine itself.
Okay, £20 for the consultation plus the drug cost. That sounds like it could really change how EHC is accessed nationally.
I think it absolutely will. Right now, lots of areas have local EHC schemes commissioned by the local council.
Yeah, the locally commissioned services, right?
Exactly. The expectation is, with this national service coming in, many of those local schemes might well be decommissioned. Wound down.
So what happens to other things councils might commission, like STI kits or condoms?
That's a really important point. There's ongoing work, particularly with the local pharmaceutical committees, the LPCs, talking to local authorities.
Okay.
The aim is to encourage them to keep commissioning those other vital services, the STI screening, condom distribution schemes, that sort of thing. Keep that local support going.
So EHC goes national, but try and keep the other local sexual health stuff.
That's the idea. And the big hope for national EHC is, well, massively improved access. You'll have this huge network of pharmacies signed up to the main contraception service, potentially fewer eligibility hurdles than some local schemes have.
Right, making it easier for people to just walk in and get it.
Exactly. And interestingly, for many pharmacies already doing a local EHC service, this new national fee of £20 might actually be higher than what they currently get paid per consultation.
Oh, really? So potentially better funding for them, too.
Potentially, yes.
Okay, let's just pull back for a second. Why does this service exist in the first place? What are the main goals?
Sure. So the core objectives are really twofold. First, to provide a sort of reliable, convenient model for pharmacies to both start people on the pill and continue their supply.
Right, the convenience factor.
Definitely. And second, it's about creating a more joined-up pathway with GPs and sexual health clinics, giving people more choice about where they go.
And presumably that helps the wider NHS system.
That's the other big aim. By offering this choice and easy access in pharmacies, it should free up some capacity in GP practices and the specialist clinics,
Allowing them to focus on more complex cases.
Exactly. People who perhaps need different methods or have more complicated health needs.
Okay, so for a pharmacy thinking, right, we want to offer this enhanced service, what are the absolute essentials they need, the must-haves?
Okay, foundationally, they've got to be compliant with their main NHS contract, the terms of service.
Standard stuff.
Yep. Then they need to formally sign up via the NHS BSA's MYS portal, Manage Your Service. Tell NHS England they're providing it.
Okay.
And critically, they have to offer consultations for both initiation and ongoing supply. Can't just do one or the other under the new spec.
Right, offer the whole package. What about staffing and procedures?
Yeah, absolutely key. The service needs to be delivered by pharmacy staff who are suitably trained and competent, and specifically for supplying the medicine under the PGD.
Yes.
That has to be a pharmacist. Technicians might consult in future, but the PGD supply itself is pharmacist-led.
Got it.
They also need a detailed standard operating procedure, an SOP covering everything. Plus, safeguarding is vital level 3 training completed, or at least immediate access to advice at that level.
And the physical space.
Yes, you need a private consultation room. Confidentiality is paramount. There's a tiny exception for maybe very small pharmacies where a remote consultation setup might be agreed, but generally it's room.
Makes sense. And what about equipment? What specific kit do they need?
Right. This is crucial for safety. You need a blood pressure monitor, and it must be one that's validated by the British and Irish Hypertension Society, BIHS.
Okay, a specific validated one.
Yes, they publish lists, one for home use monitors, one for specialist use. The pharmacy's monitor needs to be on one of those lists.
Not just any old machine.
Definitely not. And you also need proper kit for measuring weight and height accurately so you can calculate BMI. The NHS BMI calculator online is useful here.
Right. BP, weight, height, anything else.
Yes, the IT system. It needs to be an NHS-assured clinical IT system. And importantly, it needs to have what's called an API.
An API.
Application Programming Interface. It's basically the tech that lets the pharmacy system talk securely to the NHS BSA MYS portal to send the data needed for payment and monitoring.
Ah, so the systems can share information automatically.
Exactly. And it goes without saying, all this equipment needs looking after. Regular maintenance, calibration checks, cleaning all following the manufacturer's instructions, and good infection control practice. The MHRA has guidance on this.
Okay, so having the right kit and keeping it working properly is non-negotiable.
Absolutely essential.
So if someone needs contraception, how do they actually get to use this pharmacy service? What are the routes in this?
There are quite a few ways, actually. The pharmacist might spot someone as suitable during another chat, maybe when they're collecting other meds, and offer a consultation.
Okay, opportunistic.
Yep. People can also just walk in and ask self-referral to any participating pharmacy.
Right.
Or they can be formally referred by their GP or a sexual health clinic or even other NHS services like an urgent treatment center or NHS 111 might signpost them.
So lots of doors open, ideally.
That's the aim. And if a pharmacy gets a request, they need to try and sort out a consultation reasonably quickly. If they're too busy, they should signpost elsewhere.
Okay. And during the consultation?
Need to get verbal consent first and record that. And with the patient's okay, the pharmacy sends consultation details to the GP practice. Annex B in the service spec lists exactly what info is shared.
Right. Keeping the GP in the loop.
Yes. Anonymized data also goes to NHS England for evaluation, and obviously data goes to NHS BSA for payment. The pharmacist uses the PGDs to make the clinical decision about supply.
Makes sense.
And they should also be discussing other methods, particularly LARC long-acting reversible contraception, as they're often more effective.
Good point. And for the combined pill specifically?
Yeah, for COCs, you need that BMI and blood pressure check following NICE Guideline 136, though importantly, pharmacists can accept self-reported measurements if they judge them to be clinically suitable and reliable.
Ah, okay. Some flexibility there potentially. What about how much contraception can be given out?
So on initiation, when someone's starting for the first time, the supply shouldn't be more than 3 months worth.
3 months max to start.
Yep. But for ongoing supply, if everything's clinically okay and it aligns with the FSRH guidance, that's the Faculty of Sexual and Reproductive Healthcare,
Right.
then they can supply up to 12 months worth at a time.
A full year potentially.
Okay.
And choosing the actual pill.
For initiation, the pharmacist uses their professional judgment. They need to think about clinical suitability, but also best value and what's recommended locally by their Integrated Care Board, their ICB.
So local formularies come into play.
They do. And for ongoing supplies, the idea is generally to stick with what the person was on before, brand or generic, while still keeping an eye on those local ICB formulary guidelines.
Okay. And if someone isn't suitable? If the pharmacist can't supply?
Then they have to explain why clearly and sensitively and refer the person on appropriately, maybe back to the GP or a specialist clinic.
Right. Clear explanation and signposting. This has been incredibly helpful. Now, I know we wanted to give a specific shout out to the pharmacy teams in Thames Valley.
Yes, absolutely. A massive thank you, genuinely, to all the community pharmacists and their teams in Thames Valley. We know you're working incredibly hard on the front line.
Hear, hear.
And for you guys specifically, please do take some time to read through all the detailed information on the Community Pharmacy England website. It's all there. And especially get familiar with the PGDs themselves. They are crucial.
Really dig into those details.
Yes. Remember, making this service work brilliantly for patients, it's absolutely a team effort.
Good message.
And think about how you can proactively help patients. Can you identify people who might benefit from your own pharmacy records, the PMR? Or could you maybe collaborate more closely with your local GP practices to help ease some of their capacity pressures?
Practical steps pharmacies can take.
Exactly. And one final heads up for Thames Valley teams. Look out for details in your next LPC Digest about a training webinar. It's focused on this service, happening at 7:30 p.m. on the 26th of June, 2025.
Okay, 7:30 p.m., 26th of June. Check the LPC Digest.
Brilliant. So just to wrap up then, the key takeaways seem to be, well, the service is definitely evolving, isn't it? We've got that higher 25/5 fee, which is significant. We've got pharmacy technicians hopefully coming on board soon, and drospirenone being added to the PGDs.
And the big one.
And the really big one, yeah, EHC integration planned for October 2025 with its own £20 consultation fee plus the product cost. It's all geared towards better access, more choice for patients, and helping out primary care.
So it's really crucial, isn't it, for pharmacy teams listening to stay plugged in, check the CPE website, read those PGDs when they're updated, keep up with LPC news.
Absolutely vital. And maybe just a final thought to leave you with. As community pharmacy takes on this, even bigger role in contraception, how can we really leverage that incredible accessibility? How can we use that presence on every high street to push further, to improve overall sexual health outcomes, and really empower people to make informed choices about their own bodies and lives?
A really powerful thought to end on. How do we maximize that potential? Lots to think about.